A 65-year-old female, Caucasian descent, with a family history negative for GI neoplasms. She does not smoke, she does not drink, no diabetes, but presented to us with a weight loss of 5 kilograms in the last month. In February of this year, she had the onset of abdominal pain. Upper endoscopy with a biopsy was performed, in which we noted a normal esophageal, gastric, and duodenal mucosa, and histology showed an active chronic high-grade antral gastritis positive for H. pylori. Abdominal CT scan showed a 4-centimeter focal nodular lesion of the pancreatic body involving the celiac trunk and the inferior mesenteric vein. We also noticed the presence of pathological peripancreatic lymph nodes. Her blood tests, though, were otherwise unremarkable. Today, this patient will be undergoing an ultrasound of the upper GI with fine needle aspiration, and it will be performed by Dr. Centurk and Dr. van der Merwe.
Actually, as you have heard, this is a case of probable pancreatic carcinoma, a pancreatic mass in the vicinity of celiac truncus. We are performing the case with Schalk and van der Merwe from Leuven, Belgium. Antonio is managing anesthesia, and I'm going to first tell about the anesthesia. They are only administering propofol, so they are very successful. With only one agent, they would provide deep sedation. And actually now we are just below the cardia, and we see the celiac takeoff. Now Dr. van der Merwe is showing you the celiac truncus. And just under the celiac truncus, we would have a nice view of superior mesenteric artery. And when we go further down, we see some small lymph nodes in the area of celiac truncus, as have been noted in cross-sectional examination. Then we bump into the mass, which is an highly invading mass. Actually, it is very near to aorta as well as celiac truncus. And now we follow the course of superior mesenteric artery below. And the mass is measuring up to 5 centimeters. I think now we can measure the mass. Yes, it is around 4 centimeters, and appears T4 pancreatic mass. And as have been observed in this patient, in most of the time, the history may be silent for a very long time, because the pain is a late sign in this kind of lesions which are residing in the pancreatic body. This is something unfortunate for the patient, because at the time of diagnosis, most of these lesions appear to be non-resectable. Now, we see that the lesion actually is encasing the portal confluence. Schalk is showing you the exact place of portal confluence. Portal confluence is actually encased by the tumor. In itself, it is not an impediment for surgery. However, because of the arterial involvement in this case, which is up to the level of celiac truncus, is making surgery actually impossible. When we go further down to the rest of the pancreatic head, there is another interesting finding. We will see some intrapancreatic masses other than the mass in the vicinity of celiac truncus. We would show these lesions, and these are not actually lymph nodes. What is your opinion about this, Schalk?
Yeah, it's very interesting. I think we see these two well-defined round hypoechoic lesions, but they don't seem to be adjacent to the pancreas. They seem to be in the pancreas. So what do you think? Do you think these can be metastases to pancreas, or do you think that these are secondary primaries. What are your thoughts on this? Because they're in very close proximity to the main tumor, but they're very distinct. They're not peripancreatic, and they're intensely hypoechoic. They don't seem to be lymph nodes, although one would not expect a lymph node there, but certainly that is in the differential.
So, do you think elastography would be helpful in this respect, whether these are lymph nodes or not?
Yeah, I think it's there's very few studies or very limited information on the use of elastography in lymph nodes specifically, but I think one can see here that in this case this is a hard mass.
Blue hard mass, yeah.
And maybe in this case we can also more clearly define this now if we look over there. So these seem to be two hard masses in the pancreas. What are the thoughts of the audience on this?
Yeah. Actually, it is not very usual to see intrapancreatic metastasis in pancreatic carcinoma. But as our understanding is evolving about pancreatic intraepithelial neoplasia and IPMN, we see that in many of the patients at the time of surgery, some silent pancreatic intraepithelial neoplasia or IPMN may be found as well. These are metachronous lesions. And I think in this case it is a bit exaggerated because these are also observed in imaging. However, it has no practical implication because this patient is already non-resectable. But in case it had been resectable, such kind of other intrapancreatic masses would have changed the way of the surgery. For example, in a tumor which is residing in the tail or the tail side of the body may be amenable for distal pancreatectomy, but in these cases, if there is some suspicious masses in the head of the or neck of the pancreas, then the surgery will turn to be a total pancreatectomy. So in case you find a mass in pancreas, entire pancreas should be screened for other lesions. That is true for IPMN as well. Whenever we find an IPMN in pancreas, we also search other IPMN in the other sites because we know that up to 20% of the cases we would find another IPMN in another site of pancreas.
I think this clearly demonstrates as well the encasement of the hepatic artery. One can see the hepatic artery has been fully encased by tumor in this case. So it's clearly extensive tumor, and it's certainly not resectable.
Yeah, actually now there is an popular word about pancreatic resection is that borderline resectable. Borderline resectable means that the tumor invades the part of hepatic artery, but it does not involve the celiac truncus in itself. Then these lesions are called borderline resectable. However, the results of surgery are not good in these tumors as well. Anyway, this tumor is totally non-resectable.
Absolutely.
And even if you cannot observe a definite involvement of the superior mesenteric artery, as you see, there seems to be a space between superior mesenteric artery and tumor. However, even in this case, there may be an encasement of the artery with tumor cells, which is called as periarterial cuffing.
Shall we now proceed to take FNA?
Yes.
What needle would you choose and why?
22 needle, because I think that first we are going to try to achieve a cytological diagnosis. If our pathologist is able to show you the presence of atypical cells, then that will be suffice for making the diagnosis. But if there is no cell block, then we will proceed with Procore needle. And actually, the Procore needle is easy to insert in this site from stomach because the endoscope is in a straight position. However, Procore needle is more costly. Because of this, first we use the cheaper needle, and if we are able to make the diagnosis, then we would not need Procore.
Which caliber are you using?
22.
Which
22.
caliber are you using?
22. good.
22.
Yeah. Is that your preferred choice?
Yes, actually, I virtually never use 19 gauge needle for solid lesions. Sometimes in the deeper part of duodenum, if I am not able to insert 22 gauge needle, I resort to 25 gauge needle. And my personal experience is that 25 gauge needle is also very effective in achieving a diagnosis. And actually, I don't think that 19 gauge needle would add too much to the diagnosis. Now I insert the inner.
Okay. Now
Yes, please. Yes.
So how do you select the best site to do your puncture?
Yes, in this case, actually, it is a challenge to perform. Could you please hold it tight? Yes, like this. It is challenging to perform FNA because there are too many vessels around, and later we are going to show you there are some collaterals. Even if we know that the 20 gauge needle is safe in transversing the vessels, still we do not want it to happen.
So we switch it off. Okay. So
First, I fix the first part of the biopsy needle. Then I proceed with the biopsy. Could you please hold tight here? Yes. Hold tight,
So the
please.
needle will now enter the mesh from there. If one can follow the needle, you can see that it is advancing into, very well done, exactly into the lesion. And what we'll now try to demonstrate is the capillary suction technique. So maybe you can focus on this, and we will very slowly withdraw, creating a vacuum.
So I am performing a fanning technique, the so-called fanning technique. And in this case, I am trying to sample more sites from the tumor as possible. And upon withdrawing, I am changing the site of puncture in order to get tissue from different areas.
Okay.
Can you just talk us through why you might choose the capillary technique over suction? I mean, I'm not particularly a believer in this, but would you like to just talk us through why you might choose that technique?
Yes, actually, it is believed that in capillary technique, the acquisition of tissue is not different from the suction. Furthermore, in this technique, the sample would be more blood-free, and that would ease the job of the pathologist. I think that is the rationale behind using this capillary technique. However, if the capillary technique is unsuccessful, then we would go on with suction. But as you are concerned about the efficacy of this technique, there is no validated data that this capillary technique is better or more efficacious than suction. So even if you are doing the standard suction, you are not doing wrong. Yes,
Okay.
now we are going to request our pathologist to examine it and to give us a preliminary judgment about what is happening.
Single pass material was abundant, partly necrotic, and in the video you see the atypical glandular cells with necrotic debris. So the diagnosis, unfortunately, is very easy. And also you can look at this structure that is not frequently observed in fine needle aspiration, but this is a stromal structure, and these are nerve fibers that are frequently present in pancreatic adenocarcinoma. So the diagnosis is pancreatic ductal adenocarcinoma. Okay?
Are you happy with the lack of blood there because he used the capillary technique? Have you noticed that there's a difference?
Yes, but frequently in capillary technique the material is less bloody and much more the glandular structure are well preserved like this one, not fragmented. So I think that the capillary technique is better than the aspiration technique in most cases, not always, but in most cases, yes.